Okay, good morning. Thanks for coming today. For people that I don't know yet, my name is Angie Sulzer. I'm the medical director here of the pre-op clinic, and it's my great pleasure to introduce to you today Dr. Deborah Richman. Dr. Deborah Richman was the immediate past president of our National Society for Perioperative Assessment and Quality Initiative, SPACI. So she's very involved in lecturing on the topic of preoperative assessment. Nationally, she's written a lot of book chapters and numerous journal articles, editor of books. I saw her speak at the SPACI conference last February on resident education, and we are really excited to bring our residents here for their preoperative assessment rotation, where they're going to be starting off later this month, seeing patients with us in our clinic. And I wanted to take this opportunity to have Dr. Richman here so that she could kick off this rotation. And I'm really grateful that you made the trip out here from Stony Brook University. She's the medical director of the preoperative clinic at Stony Brook University. And when she was recruited to take over that role, I think they had an 8% case cancellation rate for elective cases. And then after she took over and revamped the whole process, I think that cancellation rate went down to 1%. 1%. So she knows what she's doing, and she's written a lot about residency education in particular. Our preoperative clinics are really well suited to teach preoperative assessment for our anesthesia residents, and I'm very excited to have her here today. Thank you so much.
Good morning, everybody. Can you hear me at the back? Somebody wave? Okay. Angie, thank you very much for the kind introduction. I'm going to talk today about teaching in the pre-op clinic. Just got to find the mouse because I'm a mouse person. All right. I have no financial conflicts or other conflicts of interest to disclose. And as Angie said, I'm the immediate past president of SPACI. And of course, in that role, I have to put a plug in for our 14th annual Perioperative Medicine Summit, which is going to be held in Orlando next February over Valentine's Day. So if anybody wants to bring their Valentine to Orlando and learn a lot about perioperative and preoperative medicine, this is a great venue and an intense 3-day conference. So objectives today is to look at the role in preoperative clinic and its role in medical education, look at the types of learners who could benefit from a pre-op rotation and curriculum, develop a curriculum, and really outline the process of establishing a comprehensive program for the preoperative group. What am I going to do? A little bit about the background, and then talk about the process, the curriculum, the learners and learning styles, and how we put that all together. So Albert Einstein was someone I was given a punishment essay to write on way back when I was in high school instead of detention. I come from Christian national education, very regimented education in South Africa, in white apartheid South Africa. And I looked up to this gentleman from way back. He said, education is not the learning of facts, but the training of the mind to think. So the facts are accessible, but it's really how to interpret and apply those facts is what our role is as teachers in medicine. So where do I come from? I trained in Cape Town, South Africa. I grew up there. I did my medical school and residency. And that's the ivory tower that I trained at. Groote Schuur Hospital, a beautiful big building. It's an 1,800-bed hospital. They have a new building that we moved into when I was a resident. It sort of starts down the side over here and goes all the way down the hill. That's where I did my medicine rotations. That's the E4, the black ward and colored ward, the non-white ward for medicine, a big Florence Nightingale female ward, and the male ward is out behind it. This is the trauma unit across the front, not the emergency room, just the trauma unit, the black entrance, the white entrance. And I spent many, many hours in that trauma unit getting practical experience because although it was a first world hospital, it was also very much a third world population with a third world approach to teaching. It was see one, do one, teach one, and that's what we did there. In my orthopedic rotation as an intern, because I was going the surgical route originally, this room here had a plaque outside the door. It was where Louis Washkansky that was his room from December 3rd to December 21st, 1967, after he had the world's first human heart transplant. And so this was this complete mix of education that I had back there, a mix of the first and third worlds. From there, I moved to Israel. And in a small hospital, Merkaz Refuah Emek, up north in Israel, we saw a whole different melting pot of physicians. There were people from all over the world, Eastern Europe, Russia, South America, local Israelis, local Arab doctors in my department. And the attitude was everybody had the best way to do it. They called it a patent, a play on the word of patent. So of doing it in the best way to do it. And everybody was always right. And the motto was, yeah, beseder, everything will be fine. However, there was a very academic teaching system there where everybody read articles, and it was interesting to see that somebody could give you an entire article on a very rare disease, but wouldn't recognize it when it was right in front of them. So there was this disconnect in teaching. They could tell you all the literature, but not actually recognize it when they physically saw it. We also had drills for chemical warfare, we had terror attacks, and we treated in our same ORs the terrorists and the survivors of the terror attacks. Our ORs and our emergency department were basically underground so that they could be used at wartime. Interesting and different place. And then I arrived over here at Stony Brook State Hospital in New York, and now we're truly in the first world where we have Joint Commission, ACGME, policies, procedures, all those kind of things that go along with modern first world medicine and what we're dealing with now and the education related to it. So my evolution through medical school residency and then working in Israel and later and now in the United States was sort of similar to the evolution of medical education. It started way back as an apprentice. A major change happened with the Flexner report. Alfred Flexner was a high school teacher who was asked to look into medical school or medical education, and his report was published in 1910. And he really identified that there was no process in place at all. There were no standards for testing, for teaching, for curricula, and no certification requirements for graduates. And as a result of that report, medicine in the United States changed so that goals and objectives were developed, curricula, lectures were organized, and it was a much more formalized way of teaching from that point going forward. Now, recent research, addressing the current learners, looks at different learning styles, more active learning methods, new approaches to teaching, and team-based learning, and that's where we are right now. We see a similar evolution in anesthesia education. Most departments way back when were the Department of Anesthesia or the Department of Anesthesia and Pain Medicine or Analgesia, or later on Department of Anesthesia and Intensive Care. And that's actually what my boards from South Africa and Israel are, is anesthesia and intensive care. And now a lot of departments are including perioperative medicine, and we've looked a little bit beyond just being in the ORs. And we've included a lot of new paradigms. Our patients are older, they're sicker. So much more of our cases are done on an ambulatory basis. And there's a much bigger focus on patient care and patient-centered care, in addition to looking at not just spending money by throwing it at patients because they're having surgery. That let's check all the boxes because they're having surgery and need all the labs. That fiscal responsibility that we now own as perioperative physicians is part of our role. There was an editorial in anesthesiology in 2010 by Kathy Kuhn from Duke University, and she mentioned these paradigm changes, but she also threw out a challenge about the lack of academic anesthesiology and how much we'd become so much service-based. And she pointed out that there'd been a lack of mentors. It was difficult to get funding and difficult to get reimbursement when you weren't in the OR as a billing. So as a result, there were a number of departments, including I saw the University of Colorado, that developed programs that were looking to really develop academic anesthesiology. Where that's gone, have we succeeded? That's yet to be seen, but work in progress. Pre-op clinics. Pre-op clinics started, the first one was recorded in Ilford Hospital in England in 1949, and it was really because the surgeons didn't have the time in the clinic to be able to pre-op the patients. And anesthesia jumped on board and went, this is a wonderful opportunity, because as a quote from Alfred Lee, the anesthetist is frequently confronted with patients who are not in the best possible state for the operation. So I don't know that much has changed, but anesthesia took on pre-op clinics back in 1949. What guides our pre-anesthesia evaluation these days? So the American Society of Anesthesiologists have their practice advisory, which tells us that the assessment of risks, the patient's medical conditions, etc., is really the anesthesiologist's responsibility. It's up to us to be doing this. And it should be done in a timely fashion, preferably before the day of surgery, in your sicker patients, in your high-risk patients. But could also be done on the day of surgery, but at least the paperwork should be available beforehand so that you'd have information. They didn't mandate pre-op clinics, and the reason was this is a big country with multiple medical systems, and the smaller systems are unable to actually afford, the private practices can't necessarily afford running a pre-op clinic. And it has less impact in the private sector, where you've got lower acuity patients, more ASA 1s and 2s, than we tend to see at the teaching hospitals. So they didn't mandate that we had to do it, but it is our responsibility at some point. So moving on to our pre-op clinic at Stony Brook, it's anesthesiology-led. There are a number of pre-op clinics through the country that are also run by internal meds and hospitalists. It's probably about 60% anesthesiologists from what I've seen within the SPACI group, 40% internists, and some have a combination, like the Impact and PACE clinic at Cleveland Clinic. We saw 15,800 patients last year, and we see about 80% of the elective patients. And the ones we don't see, we review the charts to make sure that we didn't need to see them. We have a hospital policy which helps us in the decision-making, in that anybody who's ASA 3 and above needs to be seen in the pre-op clinic. So the surgeons kind of figured out who and what to send to us, and if they miss one, we pick it up in reviewing the charts. And what you have done in the pre-op clinic may be your pre-op history and physical, maybe your anesthesia consult, maybe labs, or all of them if that's what you need or what the surgeon has asked us to do. We have a lot of private surgeons who get private referrals from outside, and so they send the H&Ps back to those physicians in keeping the business arrangement going, and so a lot of those patients we wouldn't necessarily see, and they don't want to send to us. We have a big staff of about 30 people. We have 7 nurse practitioners and PAs who do histories and physicals, anesthesia consults that they're able to do. We have CAs who do bloods and ECGs. We have clerks, a clinician, an office manager, 8 RNs, an anesthesia resident, and an anesthesia attending. And we're there 8 to 5:30 every day, Monday to Friday. We serve the Stony Brook University Medical Center, which is a 604 inpatient bed hospital with 23 main ORs, opening another 4 later this year, and 8 ORs in our freestanding ambulatory center, opening another 2 later this year. We also see patients going for obstetrics, endoscopy, MRI, but those are select patients that we see. And we have more than 22,000 cases per year, of which 19,000 are elective. 604 beds. Last week we were at 683, which made life a little bit interesting. I heard there's just a surge of patients lately. So what are the goals of the pre-op clinic? Our primary goals: patient safety, patient satisfaction, minimizing cancellations day of surgery, and it says 6, but it was actually 8. That's a typo, sorry. And that was 10 years ago, 12 years ago. And minimizing delays on the day of surgery, which are not always easy things, metrics to measure, but we have some things in place, but we're not measuring them. It can be a challenge. Our secondary goals: safety and efficiency, and that means completing the EMR documentation, making sure that you've got medications in for medicine reconciliation, completing all the New York State required nursing documentation, smoking cessation, abuse at home. There's all sorts of required things that have to be in there, which could be done day of surgery, could be done on admission, but easier done through the pre-op system, and our electronic record has helped us with this. We also do a very big role in patient education, NPO instructions and medication management, And if we don't know the answer, reaching out to consultants to let us know what we should be doing with a particular drug that a patient's on. We give out Hibby scrubs and instructions on their use, and we also give out information on enhanced recovery and the carb drinks to the patients where that's relevant. Our other secondary goals, and this is more the focus for today, is education, where we have a resident curriculum, and then we also have an advanced practice provider curriculum. The LIPs that work for me do anesthesia consults on a fair number of the patients, and usually they have not got an OR background, not to mention not having an anesthesia background. So there's a lot of training and curriculum that goes into that. And then we have a number of rotating students, dental residents, some ER residents, internal med residents that come through. And another part of our academic mission is we have a study coordinator from our department who's there pushing recruitment for our clinical trials. So when you've got the academic mission of wanting to teach in the pre-op clinic, this gives you a number of opportunities. And having a dedicated preoperative program, which Angie is now doing here, is really something incredibly useful beyond day of surgery within the hospital. Firstly, you have a department expert, somebody who's attends things like the SPACI Summit, and that's where I first met Angie, who is able to network, one-on-one in a group this size. Well, it's a little bigger than this, but the conference with people like Francis Chung, who's the OSA guru, Lee Fleischer, who's the AHA guideline guru. So these are the people that we know through SPACI who are part of it, who are on our board, who people are able to have the opportunity to really discuss things. What does this really mean? Where did it come from? You also, by having a dedicated person in charge, have supervision that's consistent. You develop a curriculum, you develop clinical pathways and protocols, what to do in certain circumstances. For instance, until recently, we didn't do any deep brain stimulator implantations. So when we got a patient with a deep brain stimulator, it was like, now what? So we now have a clinical pathway. When someone walks in the door, we don't look silly and say, why does your ECG look so funny with all that interference? We say, oh, do you have a deep brain stimulator? And let me pull out the pathway, and we follow the steps, and things flow nicely, including to calling the rep, whose number's right there on the pathway. So there's those kind of things we have in place, NP and PA education. And then another important role is outreach to both the departments and to the community. I've given grand rounds at a number of our departments. A recent one that I did was urology. Urology was bringing too many patients to our freestanding ambulatory center who weren't candidates. And then we were seeing them a week before surgery and now having to get them into the main OR. Patients were upset. The surgeons were upset because they just weren't candidates for there. So gave them a grand rounds on ASC eligibility that was specific to us. And this has completely changed, and everybody's much happier. And I'm a face, and now I get a lot of phone calls. They have me on speed dial. Like, what about this patient? What do you think? But it makes the process so much smoother, and their interaction and communication between the departments is much better. And community, in terms of the private providers, the PCPs, of what our expectations are in terms of medication management perioperatively, we have a lot of connection with them as well. So, education in the pre-op clinic. When you're learning something, you're learning knowledge and skills and attitudes. There's three things that you want to teach. Knowledge is obviously the straightforward medical knowledge. Skills, like interview skills. And attitudes is much more sophisticated. How to deal with a patient who's got a DNR in place. You discover that in the pre-op clinic, and you don't want the patient to have a traumatic discussion on the morning of surgery just before their procedure. So we initiate that. And we have a box of tissues in every room because we have a big ALS clinic. We have a number of patients who come through with us. This actually does come up. And the sensitivity to this type of patient and their wishes is part of what we train and teach. The big challenge is integrating this into a busy clinical setting. So you've got patients to see, and now you've got to teach. How do you do it? So you need to do it effectively, and effectively means that your residents are scoring well on their boards and their in-training exams, because if your board scores are good, your RRC reaccreditation, I mean, that was one of our issues when I was hired, is that we were doing very badly in perioperative medicine in the board scores, and we weren't having as high a board pass rate as we should have, and RRC was looking at us closely. You need to engage your learner. What they say is this high-yield information. So that's the one way, but there's other things about engaging the learner and making it very much learner-centered so that they can respond and retain the information. We have to be compliant with the ACGME, and there you run into duty hours, and that becomes a great difficulty because it limits your time. And then obviously with all the teaching or having residents seeing patients in the clinic, they've got to be covered to make sure that the patients are safe and that the patient satisfaction scores are not impacted by seeing a resident who didn't know anything or looked like they were 16, or because some of our residents do, and the older I get, the younger you guys, the residents, look. Additional challenges to the educational mission. There's an incredible volume of medical knowledge. Anesthesiology, one of our journals, publishes more than 9,000 articles a year, which means you have to read 25 articles a day, 7 days a week, just to keep up with what's in anesthesiology. So it's having people who are experts in the pre-op world be able to know what's out there. And a lot of knowing what's out there is networking with colleagues. Hey, did you see this? Or this has just come out. And we, often on the SPACI website, we say, look, there's new guidelines out. This was just published, so that people will know about it. The other challenge of the ACGME that I mentioned earlier with the duty hours and the other requirements, all the documentation that the residents now have to do. There's financial costs. If you're pulling residents from seeing patients, someone has to see those patients. And in addition, if you're pulling teachers, faculty from seeing patients to teach, someone has to take the clinical load as well. So there's those costs. And Miller, in an editorial in ANA, in 1998 already recognized that with the more duty hour guidelines, and that's before the 2003 and 2011 guidelines, had educational impacts. The residents and the learners were not being exposed to as much. There was an article by Sanjay Desai out of Hopkins that was published in JAMA Medicine in 2013, and this has looked at the 2003-2011 duty hour regulations, and they had three groups. There were, I think, 1,600? No, that doesn't make sense. I'm sorry, 400, I think, something residents that they were looking at a randomized crossover trial where they had them do the old-fashioned Q4, which was the 2003, and then the options that were compliant with 2011, the Q5 call and the night float call. And they were looking at, did it affect training? Did it affect resident well-being? Specifically, did it affect resident sleep? And was there safe and efficient patient care in these different options? So there was definitely improved sleep amongst residents who were doing either the night float or the Q5 rotation on call. However, educational opportunities were significantly decreased. The Q5 and the night float residents had less admissions and followed less patients. This is in the medicine wards. 25% reduction in attendance at noon conference because you just weren't physically in the hospital because you were home sleeping, so they were missing noon conference educational opportunities. And in addition, there was an overall 30% loss in educational opportunities in not attending and teaching rounds. From a patient safety point of view, they found that there were many more handoffs both in the night float and the Q5, and in their particular instance, the night float arm was terminated early because of, they found there were issues with quality of care because of these handoffs. So yes, they get better sleep, it's better for their well-being, but it impacts on their education. So let's look at structuring your process for success and how you set up a program. And there's a whole checklist here that I'm going to run through and touch on each. Your education leader, the person in charge, needs support from the department, some time, some administrative time, and the ability to increase their own exposure and learning to pre-op medicine, because there's a lot of articles out there and a lot of information out there, and it changes all the time. You need an individualized plan for your trainee, and there's multiple different trainees that you will see in clinic. The residents is our primary focus. We at Stony Brook have dental anesthesia residents who spend 2 weeks with us in their intern year and then another full month with us as dental anesthesiologists. They're the same as our anesthesia residents when they do their senior year rotation. There's our nurse practitioners and PAs who need their education. We host visitors from other pre-op clinics who are just coming for a one-day visit to see how it's run and how we do things. And at all levels, our clinical assistants who are doing the ECGs are looking to say, you know, are my leads right? When should I be looking at moving my leads around? Because we've had way too many anterior septal infarcts because someone didn't take the bra off, because the patient's sitting in the wheelchair, because they'd had surgery and it was a male who didn't feel like putting the lead right there, and V3 causes an awful lot of lead placement infarcts that are not real, and you save the patient a ton of runaround and echoes and cardiac consults for an infarct that's not real. We have medical students, and we don't have, but there are places that have perioperative medicine fellows, which is usually a 1 year, 0.5 FTE where you're a faculty fellow. You're doing a 1 year in perioperative medicine, but part of the time you're doing either your anesthesia because you're an anesthesiologist or internal med because you're an internal med. Some of those curricula include management of ORs, management of periop as well. You need to individualize for your learner, and don't forget the very important person, the patient, and their family members. There's vast educational opportunities. Don't miss that teachable moment. Most people stop smoking when they have their MI. That's the day of the last cigarette. Sometimes you can use pre-op, and that's been shown in the literature, as you're having surgery. Today's the day to stop smoking. And that input in us is that teachable moment, and we should be using that. We need to give the patients information. We always think of taking a history, and that's why you're seeing them, but it's really sharing information. That leads to successful outcomes. And we have handouts, written handouts for the patients on NPO, on medications, on enhanced recovery protocols so that they know what they're doing and specifically write down to do with their medications. This, for example, is one of the handouts that we give to patients. Where to go, and they have a contact phone number in case they are lost on the day of surgery, and a contact phone number for us in case they have any questions. And so they've got a backup plan if after they leave us, oh, I didn't ask. All right, there's a next part in your process is an introductory handout. We have something like a 16-page introductory handout that goes to the residents before they start. It's mostly alphabetized. What do you do with a patient with a pacemaker? What do you do with a patient with a latex allergy? So once you get the gist of it and you see what the titles are, you don't need to read all those pages, but it also introduces the staff, gives you suggested reading, tells you the hours, hand washing, all those other things that we're kind of obliged to remind people to do. And it also has a sample of a note so that people can then take that note and make their note individualized for their pre-op rotation, because they haven't made pre-op notes prior to this. There's a template, but they can individualize it to really meet their needs focus and understand what we're looking for. Then we move on to a pre-test, and a pre-test is always like one of those things you're kind of obliged to hand out and collect back and say we did it in a post-test, and it's looking at data and did you make an impact. But there's also a significant role it plays on identifying to the testee what they're missing. And once you know you're missing something, you'll pay more attention when it gets taught. So it's not just data management, it actually works at the individual level. And for the teacher looking at it, oh, wait a second, this is completely blank. And if you see it as a repeated thing within a department or a rotation, maybe that's a place for grand rounds. So the pretest has a role as well. Goals and objectives of your rotation, and this is a screenshot of mine. Don't even try and read it. I'm not going to read it. But we have 6 goals and objectives. The first one is about taking a history, including the reason for the surgery, past history of medical illnesses, what medications you're on, etc. And in it, it addresses the ACGME requirements of core competencies. So it's this particular one is patient care and interpersonal and communication skills, etc. And you can list it there. So we have this on file for when we get our reviews. We also have goals and objectives for physical exam, labs and consults, anesthetic options, which they have to discuss with the patients, and then the ability to present a cohesive picture of who this patient is, both to the attending and in the note, because they're seeing a patient, hopefully in our case, 2 or 3 weeks before surgery, and what you want to be able to do is pick up the chart the night before and go, oh, I know about this patient. You know, you'll get 45-year-old multiple sclerosis going for bladder surgery. Well, neurogenic bladder is or going for kidney stone surgery. That suggests they may be in a wheelchair, but there's no wheelchair in the note. Paint the picture, because that's what you have. That's all you have the night before when you're planning and coming into this patient. And nobody likes surprises if we can avoid them. We also have advanced goals and objectives, so that if you have senior residents coming back on elective through the clinic, you're now looking at your history, cultural sensitivity. Physical exam, not just, oh, I hear a murmur, but let's differentiate between murmurs and their implications. Additional workup, you may have a role here for doing transthoracic echo, which some clinics would offer. And so you're teaching that particularly in an advanced rotation. When you're discussing anesthetic options, postoperative cognitive dysfunction assessment, and risk discussion with a patient. So those are more advanced goals that you would have. Okay, then you schedule, and obviously you're assigned supervisors, and again, consistency is very important. And moving on to curriculum. So what do we have that guides us on the curriculum? Again, back to ACGME. The requirement of ACGME is a minimum 2-week uninterrupted rotation within the residency, anesthesia residency. And Simmons et al. from a abstract that it was published in 2005, talks about as an ideal place to teach all the competencies, your patient care, your medical knowledge, your professionalism, etc. It's a very good place in the pre-op clinic. You're not just in the OR with medical knowledge. There's the communication. It's a place that does it. And as I mentioned before, the board pass rate is important for reaccreditation of your program. And there's a big section on perioperative medicine, so this is the place to teach it, to improve test scores and therefore pass rates. The ABA gives us a content outline, and this is straight from their website. Evaluation of the patient in pre-op preparation, physical exam, including airway, etc. There's a big blurb there, but that's not really a curriculum, but that's really all the guidance that they give us. So Angela Bader out of the Brigham, and she's one of the board members of SPACI, in fact, one of the founders of SPACI, runs their pre-op clinic together with David Hepner. And back in 2000, this is a while ago, they did a survey that they sent out to all places that had an anesthesia residency. They got 112 completed surveys back. 90% of people answering the surveys from the program directors said that a perioperative or preoperative curriculum was important, but less than 50% of them actually had a curriculum. 18% of attendings who covered pre-op clinics or pre-op processes, because not everybody has a clinic, had an interest or an expertise. So the other 82% were just there for the day, covering the unit, and that was not necessarily a useful use of an attending. And only 53% of programs were teaching patient interview skills. So the things that you were there to really learn, they weren't doing. Have we improved? Well, my clinic was surveyed, and no, we didn't have someone with an interest, and no, we didn't have someone there. Yes, we've changed. So there's no no survey published since then. And this is just results from their survey. Other mouse. Okay. 8% had no pre-op clinic, and 24% who did have a pre-op clinic didn't have their residents go through there. So only 60, much lower percentage of residents even went through a pre-op clinic. And 57% of clinics had an attending physically present. Some had none at all. 43% had an established curriculum. The earliest curriculum that we see in the literature in the perioperative world comes from John Tetzlaff and colleagues out of Cleveland, and they put together a perioperative medicine, so not pre-op, perioperative medicine curriculum, and they lumped together 2 4-week rotations that the residents went through in their CA 1 year, and that included the pre-op clinic, the same-day surgery admission unit where the patients came in in-house consults for patients going to the ORs, and the PACU. And that was their curriculum they put together. And there's different ways of structuring it. After they introduced it, it was one of the highest rated rotations by the residents. It was really in the top 10% of rotations at Cleveland Clinic. It was very popular because it was dedicated and structured, and the residents felt they were getting a lot out of it. There are a number of perioperative fellowship curricula available in anesthesiology out there, or programs rather. 7, according to Elena Kupke in the ASA Monitor that was published earlier this year, there's 7 perioperative programs in the United States, and 24 out of 149 academic anesthesia departments include perioperative medicine in their title. So we're still the Department of Anesthesiology, but a lot of people are now Department of Anesthesiology and perioperative medicine. So it is a growing field. The programs are structured mostly anesthesia. There's one that's mixed. There's one that's based on the Memorial Sloan Kettering, as it focuses on the cancer patient. And the one that's out of Brigham's looks a lot at a combination with OR management and quality improvement as well. It's not just perioperative medicine. And there's just some of their websites that show you what's out there. You can find them. So our resident curriculum, the basic outline of it, the bare bones of it, and these are the topics that we want to have covered. Curriculum comes from curare, which is the Latin word for run, and is really to run a course or run a racetrack. And so this is where you want to go through this. I guess the running goes with how busy we are. But you start with an introduction. What's the role of the pre-op clinic? What does it offer? And then the patient-related and surgical-related factors. The next thing you need after your curriculum is a password and keywords, and this is the carrot and stick phenomenon. The resident wants to learn, the attending doesn't have time to teach or doesn't want to teach, and if you have to actually get the signatures, you can have the main topics that need to be covered in your 2 or your 4-week rotation in the clinic, and they get the signatures along the way, and therefore there's an obligation when you've got non-regular staff covering the clinic to actually do some teaching and get this going. And it's useful, and I think we all do, have a set of can talks of things that we like to talk about and use the opportunity to bring up. And if you can share out the can talks amongst your various faculty, you'll find that the residents will get a fuller experience. So if you've got someone in pain management who's working in the pre-op clinic, you would be working, looking at the patient with chronic pain and how to manage them perioperatively. Someone who has an ambulatory or office-based anesthesia practice more can look at eligibility for patients for those surgeries and the difficulties that are there. We have a set of lectures, so moving on, and we have a set of lectures that we have a teaching session in the pre-op clinic every Tuesday lunchtime. We actually close the clinic for an hour, and we have a 45-minute lecture session. It's case-based, so it talks about the specific title for this example was lithium therapy, but it was really a bariatric patient who presented to the ED post-op in lithium toxicity because she lost 50 pounds in a hurry. And so that was just looked at the approach to the bariatric patient and medication management, and how sometimes medication management needs to be thought out a little beyond the discharge as well. These talks, obviously a resident on a 4-week rotation is only exposed to 3 or 4 of them, because sometimes they actually do one of them. But the practitioners in the clinic will get a curriculum through the year that we kind of go through and update over a year or 2 years, depending on the topic and the changes to the topic. But they're all available in a shared drive where everybody can access them at any particular time. And then in addition, I give some specifically related pre-op lectures to our residents as a group within their teaching days throughout the year, looking at HA guidelines, OSA management, etc. Feedback. We need to give both formative and summative feedback. We use new innovations. This is just a screenshot from there. What did we teach today? What can the resident do to improve based on today? So they didn't wash their hands more often. It's a way of telling them and then documenting it, and then we have something similar at the end of the rotation where the group discusses the resident and there's a more formal feedback. We also have an end of rotation exam, and the exam is, asking questions about what they should have seen. So if we haven't covered a topic, it actually touches on that. Multiple choice questions, especially with double negatives, are difficult, so watch how you phrase your questions. But certainly millennials like the like, dislike, rather than true or false, and they're testing better. So you've got to also look at your audience. And talking of audience, who are our audience, our learners? If you look at the old-fashioned 1950s structured nursing school with everybody in their caps and everybody standing to attention and all skirts at the same length, we're not there anymore. This was my medical school class, and Anthony used to sit there, and he was always asleep, and the lecturers all knew Anthony's name because they were always waking Anthony up in the front row. He now works in Detroit. Okay, another one of us transplants. Medical school concentration during lectures. Stewart and colleagues back in 1978 in The Lancet did a survey-based thing of 13,000 surveys they got back from 12 different lectures, so these were big groups. And med students were saying, really, 10 to 15 minutes is how long we're concentrating. So I don't know about you guys, but we have some 2-hour lectures at our hospital for med students and residents. And the time is really important in terms of the lectures. It's just not the way people are learning. Bly, in his book, What's the Use of Lectures, in 2000, actually looked at student heart rates in class. And if you see here, I have a mouse. If you see here, by 15 minutes, most people's heart rates have gone way down. And occasionally there's a blip up when there's an interaction and a question to a student. But really early, we're kind of zoning out. And so we got to look at the role of lectures very carefully. This is who we're teaching now. The millennials, this connected group effort population, the so-called Generation Y or Next Gen, born between 1980 and 2000. And they're the people that are learning. They're also going to be 50% of our workforce in 2 years and 75% of our workforce in 2025. They like to work in teams. They're constantly connected. And a very important thing, which doesn't go from certainly the generation before mine and probably even mine, they really value free time. And so it's not going to be sitting in the books all day, every weekend. So we need to look at reaching out to this new generation of learners and how we do it. And V.G. Kurup, who's from Yale and very involved in medical teaching, she had an editorial and an article in the Current Opinion of Anesthesiology back in 2013, where she said, if you look at medicine, there's incredible technical advances, but education, we're still standing here with a PowerPoint. And we haven't really done the same as other fields have done. And she made the suggestion in her article in that journal about the use of blended learning. So what is blended learning? That's both where you're doing online learning, not just online or book learning, because books have gone, it's all online now, but online and human interaction. There's a lot of technology out of there, which makes it time efficient. You can speed up talks. You can skip around and just read the key points and then come back, and it's easy to come back. It's not flipping back through pages anymore. It works well for different learning styles. What's nice about it allows for asynchronous learning, so that if you're on call right now, you can log into this podcast at midnight tonight and look at what happened this morning at Grand Rounds that you missed. So there's certainly a lot of advantages, and this is one of the things that we're using with teaching millennials. Does it work? So there was a survey out of the Department of Health, Department of Education, and this looked at a literature review, non-medical, looking at K through 12 students, and was online learning useful? And they found that in the school system, online learning did slightly better in test scores. But it was even better if it was in combination with a person giving a lecture. So the combination worked well, but it certainly was slightly better than the old-fashioned let's sit in class method. What about in medicine? Does live lecture, which is better for undergrad medical education, this was a randomized controlled trial, and they looked at students. The students actually preferred the live lecture. However, those who learned through the podcast or those who learned by coming to class scored the same on testing. So the convenience of the podcast, that, I can't get to lecture, I'm doing something else, I'll catch up later, is wonderful, but they found it less engaging, and they really actually preferred the live lecture, which was kind of a little bit surprising because nobody seems to come to lectures anymore in now. So their conclusion was, yes, there's very much a role, but choose wisely on what you put there, and you probably should be putting facts on your podcasts and on your online learning. But critical thinking skills, how to interpret things, is what you need the lecturer, the teacher in front of you to help you work through. The other way of teaching millennials is what's called the flipped classroom. And here what you do is you're told the subject for today is, and I'm going to come to an example. So the subject for today is cardiac stents and their perioperative management of their dual antiplatelet therapy. And tell my resident to read about it tonight. So they go home, they read at their own pace, they look things up, and then now tomorrow you need to have a group discussion on what to do with this. And now you have a faculty who leads the discussion based on reading that's done. So you're not teaching the basic dry points. That's done already, that was done at home. And then the homework, essentially, what you would normally have sent someone home with, the homework, you're doing in class together. And the outcomes, where we went with this, why we read it, that's been done in class to make sure that it's understood. And then you can revise again. So the old-fashioned sage on the stage, me standing here, becomes the guide at the side. Let's work on this together in our group and guide them, but they have the knowledge to start with. And that's the flipped classroom. They say teachers are less bored. If you give a CAN lecture, and I give a CAN medical school lecture, med student lecture every 2 weeks, it's less boring if you do it this way. But initially, there's a lot of resistance from teachers who are used to giving a lecture, and you've got to change your way of thinking and set up how to manage this constructively. A little bit of work, but then there's increased teacher satisfaction. So our role in resident education, we need a knowledge base, we need good teaching principles, we need a structure, we need information management, and we really should be using technology as a tool. We should be modern these days. There are a lot of programs out there that you can use to just send a quick survey around to your group of residents and say, hey, what do you guys think of this? Like the pretest. And it comes, it grades themselves. Google Forms has one, very easy to send out. You can actually use them, pop them right up on the screen. I didn't do one because it actually takes a few minutes to do. Social media. When something comes out within our society, the SPACI has a Twitter account. New guidelines go on the Twitter account, not just on our website. And then anybody who's following gets to see that. So that's a way of disseminating information. Can be done at the resident level too. And you can have a wiki program where everybody can come in, add their bit, edit it, and that's the next step from your flipped classroom. You prepared something at home, you now have a document, and that's the document you would study from later on, where everybody puts into this document. Like Wikipedia, but would it be a local one that you would have? So let's look at the example, and then I'm going to end there. The cardiac stents. So the flipped classroom example. So when you tell the residents, I'm going to talk about stents later on, they Google stents, and they come up with Lee Fleischer's 2014 AHA ACC guidelines on the pre-op assessment of patients with cardiac disease. And they come up there with, you should continue the stent, depending on whether it's bare metal or a drug-eluting stent, you can stop the Plavix at such and such a time. Then, if they look a little bit further, because it's not where they're trained to look, there's the 2016 update on dual antiplatelet therapy. And this wasn't just in the perioperative period. This was for cardiology in general. The lead author is Levine, Jeff Levine. Lee Fleischer is the author of the peri-op section, and I almost want to say silo because it ended up being a silo within the guidelines of what to do with stents. And this was based on the newest information and the newest stents. So if you look at the guidelines, let's now apply it to a case and make it memorable so they can say, we're thinking about this. What are we going to do with it? So we have a 38-year-old mom of 2. She had an MI 9 months ago and at the time got 3 drug-eluting stents and was told to go on to dual antiplatelet therapy for 12 months. She now plans a combination of surgeries, a breast reduction, a tummy tuck, and just, by the way, I've got endometriosis, so they're taking out an ovary, and that's kind of driving the whole. And we've put together 3 surgeons, and we want to go ahead. Applying the guidelines, if you look at the 2016 update, when can you have surgery after an MI and dual antiplatelet, it says 6 months. So this 9 months out seems reasonable. If you look at the other half of the 2016 guidelines, because it was an MI, an acute coronary syndrome, and not an elective cath for angina, she really should be on her dual antiplatelet for 12 months. But when we moved to the surgical side, they left it in that surgical silo and said 6 months for everybody. And it's probably safe, we're not sure. There's more studies, more literature coming. So seems reasonable to proceed looking at the guidelines. She can hold her Plavix at this point, but she's on her monotherapy, her aspirin for life. And the plastic surgeon is willing to do that. Now comes the guide at the side. Okay, let's look at this. Does this make sense for this 38-year-old mother of 2 young children? So, history. How do we look at it? Balloon angioplasty. You popped in a balloon, you popped open the artery. Great, life's good. 3% acute collapse of that artery, rush to get a cabbage to hold it open. All right? And then there was a 30% restenosis rate over the next 6 months, but 75% of patients did great. Fast forward 10 years, bare metal stent. You pop open the artery, you pop in a bare metal stent. It holds open the artery, but you're still left with that 6-month, 25% or so restenosis rate. So it solved one of our problems. And that was easy. Move forward another few years. Drug-eluting stents approved in the United States in 2003 and 4, the sirolimus and paclitaxel stents. Anti-proliferative drugs are on polymers on the struts of the stent, and they elute over time. And what are they doing? They're preventing anti-proliferation. They're preventing scar tissue, smooth muscle scar tissue, and the scar tissue is what's contracting and causing that restenosis. So whoopee, we've got our restenosis rate down to under 10%. Anybody my age remember the bare metal stents going for surgery? You got a stress test at about 6 months before you had your surgery to make sure you weren't the 1 in 4. That went away once we started putting in the drug-eluting stents because it's almost not happening. But there's a side effect. And the side effect is that same drug that's preventing scar tissue is also preventing endothelialization until the drug is eluted. And initially, they said 3 months and 6 months, depending on the stent. Suddenly, timeout, 2007, FDA says, whoa, everybody needs to be on 1 year of dual antiplatelet because there's this risk of late in-stent thrombosis with a greater than 30% mortality. What happened? So what happened was when they tested the drugs, and they came up with 3 and 6 months, they had specific inclusion criteria. These were unlabeled stents. Essentially, they were shorter, big diameter stents in single vessels, not by bifurcations, causing laminar flow to become turbulent flow. So flow was preserved through the stents. They were in non-diabetics. They were in preserved EFs. And so now the question is, what makes the drug elute? What makes the drug elute is washout of that drug. And what is washout? It's flow through a tube. And these days at Stony Brook, 70% of our stents are placed are off-label, not on-label, according to the original study criteria. An article in JAMA 2007, at the time of this whole big stent crisis, also showed that a majority, 59% treated more than one lesion. 53% had long stents. And why does this matter? Hagen-Purcell, your flow through a tube is affected by your cardiac output and length, diameter. So essentially, it's unpredictable when you would re-endothelialize and when you would be ready to go ahead. So let's go back to our case. The guidelines say she can go, but can she go, and do we know enough? And do we want to take a risk in this young patient for a very elective surgery? So we ask for the cath, and we get the stent details to see what type of stent she has. Now, obviously, she's off-label because she has 3 stents, just right there. But are they one after the other? What's their length? What's their diameter? And here, the guide at the side can give advice on how to proceed with this patient. So in summary, the pre-op clinic is a wonderful opportunity for teaching because of the volume and variety of cases. It's the ideal setting for teaching both knowledge of medicine, interview skills, which is a competency, attitudes, which falls under communication, and you need to individualize your teaching for your needs and your resources. The most important thing is a dedicated person and structure. And I want to thank you for your attention and leave you with some words from Nelson Mandela, who was imprisoned the year before I was born and released when I was a 4th year out of a 6th year residency. So at that time, he'd been in prison for longer than I'd been alive. Phenomenal man who really can teach people on how to behave and attitudes. And he said, education is the most powerful weapon which you can use to change the world. So let's change the world a little bit each day. Thank you very much.
Any questions?
Any questions?
We have time for a question if anyone has a question. Or you can come down and talk to Dr. Richmond while she's here. Okay, thank you.